Good afternoon, and welcome to Internal Medicine Grand Rounds. There is no commercial support, and the speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the events survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Aleksandra Ignatowicz. Dr. Ignatowicz is a third-year internal medicine resident here at Northeast Georgia Medical Center. She is from Augusta, Georgia. She attended medical school at the Philadelphia College of Osteopathic Medicine, Georgia. And after completing her residency, she will continue working as a hospitalist in Tampa, Florida. Join me in welcoming our guest speaker.
Thank you for the kind introductions. I will be talking about things we do for no reason in hospital medicine. So I have no financial concerns or conflicts of interest. So learning objectives for this topic is to understand the significance of high-value care when making medical decisions, identify common practices not supported by evidence-based medicine that provide little value to our patients, and understand the significance of staying up to date with both diagnostic and treatment criteria. So what exactly is high-value care? It's value-based health care that aims to improve outcomes while decreasing total cost of care by avoiding unnecessary services. And really the best way to do this is to understand the benefits, the harms, and costs of interventions, and then choose a cost-conscious care plan. Now, common practices that provide little or low-value care, these are divided into about 4 criteria. So we'll start with the lab testing. So this is routine labs on all patients, including patients that are prepping for discharge and those that have been stable. Ordering T3 or T4 when TSH is inappropriate, procalcitonin after surgery, trending BMPs during a hospital course for a patient with heart failure, testing for amylase over lipase in acute pancreatitis, routine respiratory panel, and then ammonia levels in HE. On imaging, we'll see people order TTEs in low-risk patients, EEGs and headaches, daily x-rays, CTA pulmonary and low-risk PE, and CT brain for delirium. On medications, so typical antipsychotics in dementia or those with delirium, Docusate for constipation, opiates for low back pain, Septanir for UTI, or antibiotics for upper viral infection, and then discontinuing buprenorphine when treating acute pain. On the consult side, we have consults to nephrology for urgent dialysis after contrast exposure in ESRD patients, consulting ID for blood culture contaminants, and heart failure consults for stable CHF patients. So what are potential barriers to high-value care? So I'll go into 2 sections. We have a system-based level, and that will include lack of guidelines, sometimes with lack of evidence, time constraints, getting patients discharged quickly, lack of available information on previous tests, and this goes back to really EMRs. Not every EMR is accessible in different hospital systems depending on what is available there, and really also the local culture of the hospital. On an individual level, this goes back to poor familiarity with guidelines, lack of time to explain things to patients, at times it's patient expectations, discomfort with diagnostic uncertainty, and lack of appreciation of harms and lack of knowledge of costs. And lastly, defensive medicine. So what exactly is defensive medicine? It's performing unnecessary diagnostic tests, invasive procedures, providing treatments or hospitalizations to avoid exposure to malpractice litigation. These are the we don't want to miss anything, or you never know what they may have. All right, so just because it doesn't look like this, it may still be this. And the driving force is anxiety due to uncertainty. And sometimes it's even disclosing that uncertainty to patients. This can later translate to higher charges. Not being up to date, and my personal favorite, not providing cost-conscious care due to concern of personal finances. So physicians have an ethical duty of doing what's best for the patient, but they still have that responsibility to society to practice effective health care that uses resources responsibly. So what are the risks of litigation? Studies have shown that 93% of physicians report practicing defensive medicine, but despite all of this, it really doesn't prevent malpractice litigation. In a study from 2002 to 2005, 4.5% of claims resulted in trial verdicts where 80% were in favor of the physician. On an internist side or internal medicine subspecialty, that even went down to 2.7%. And really the guidelines say that as long as you're following evidence-based guidelines, you should be able to prevent malpractice litigation. So what are factors that contribute to low-value care? So we'll go into the three sections. The first one would be knowledge. So this again goes back to diagnostic uncertainty, not understanding the costs of tests, images, procedures, lack of training where there's weighing the relative cost and being thorough and really, relative cost and benefit to these studies. And there's the desire to be thorough and have a complete workup. And this was what the $1 million workup is that we usually joke about. In the process of care, we'll rush to make decisions or have preemptive decisions, duplicate tests will be ordered, and then it's really easy to access multiple orders on Epic or any other EMR while inpatient. Now, the hospital and program culture is another factor. We as residents imitate our team dynamics and our attendings' decisions. Faculty can expect certain workup or certain procedures, and oftentimes it's a result of defensive medicine or a case where it's just what the patient wants. So how can we prevent practicing low-value care? It goes down to identifying high-value care and low-value practices that are most applicable to our day-to-day routines, and once that's determined, making longitudinal changes. So what can be done on a system level and on an individual level to teach high-value care? This goes down to implementing high-value care really during residency. The attitudes and practices that physicians develop during training often shape future practices. So what we can work on is articulating the importance of high-value care to patients, to their clinicians, to society, to our hospital, discuss the cost implications in different scenarios and the evidence-based guidelines that support appropriate diagnoses and treatment, and then identify the clinical reasoning tools to assist with management, and then later integrate these concepts in behavior and training. So ACGME does apply these concepts in their core competencies. There are guidelines on how we as residents are evaluated. They mention evidence-based medicine, and they also mention being cost-aware, and then understanding the risk-benefit analysis in patient care. ACP also has a free course on how to determine and define features of low-value care and high-value care, and ultimately how to combat it. Outside of residency, we have ABIM, or the American Board of Internal Medicine, created the Choosing Wisely campaign, and that led to the formation of Things We Do for No Reason series in the Journal of Hospital Medicine. They review cases that are common practice, but ultimately provide little value for patients, and then are able to provide examples of what would be a high-value care situation. So these are several graphics. Each article is relatively short, easy to read, and they do provide graphics with what the issue is, what can be done to mitigate it, and then ultimate guideline recommendations. And the Curbsiders also joined with Society of Hospital Medicine to create podcasts to support this. So next on, what are things that we do for no reason in hospital medicine? This will be interactive, so please answer. All right, so a 52-year-old male complained of epigastric abdominal pain and 1-week history of black Antari stools. His only medication is daily ibuprofen for migraines. On exam, his blood pressure is 110 over 160, heart rate is 105. Other vital signs are normal. Physical exam revealed epigastric tenderness without guarding. FOBT is positive. Anorectal exam shows no blood or stool in the rectal vault. Which of the following are appropriate therapies?
So do you want someone in the audience to answer?
Yes.
Okay. Say it again. We're going D, B, and C.
Yes, and D is correct. All right, so why do we keep performing FOBTs? So the U.S. Preventative Task Force and the American College of Gastroenterology initially recommended FOBTs as a method for colorectal screening in average populations, but that's been replaced by FIT testing. due to increased sensitivity and specificity. And part of that is we do have false positive tests, and we also have false negative FOBT, so indications for false positive if there's any kind of ingestion of blood from extraintestinal sources, contaminated samples with hematuria or menses, intestinal mucosal inflammation, or just clinically insignificant GI losses from medications such as aspirin, NSAIDs, SSRIs, ingestion of meats or fruits like cantaloupes or vegetables, broccoli or cauliflower, and then causes for false negative are slow and intermediate bleeds or vitamin C intake. So FOBT should not be used to diagnose upper GI bleeds. It's unnecessary in our high-risk patients or even those that are symptomatic. The false positives result in unnecessary GI consults, procedures, increased healthcare costs, and prolonged hospital stays. And the best tool to diagnose an upper GI bleed is really a good history and physical exam and visual inspection of the stool. And we should suspect a GI bleed if there's any reported history of melena, if there's melanic stools or blood clots in the stool, or nasogastric lavage shows blood or coffee grounds, or serum BUN or creatinine ratio is greater than 30. Now, treatment for upper GI bleeds are PPIs. As we well know, there are increased risks with PPI use, vitamin, mineral malabsorption, bone fractures, pneumonia, viral gastroenteritis, or C. diff infections. But one thing that we know that we're probably less likely familiar with is really PPI use with high-dose steroids. So why might a PPI be useful with high-dose steroid treatment? It's believed that steroids contribute to peptic ulcer formation or gastritis by inhibiting the gastric mucus and prostaglandin release, and then that can ultimately lead to GI bleeds. But really that's not necessarily true because steroids are not ulcerogenic. They only inhibit COX-2 and not COX-1. COX-1 is used to protect the stomach lining, and then COX-2 actually helps with healing gastric ulcers. So when should we use PPIs on high-dose steroids? So there's a list of high-dose steroids, but really steroids themselves, you don't need a PPI. PPI should be added if there's concurrent use with aspirin or NSAIDs or anticoagulants, or if a patient has a history of peptic ulcer disease or they are already high risk of GI bleeding. So the patient develops abdominal distension, was found to have ascites on imaging. He endorsed drinking 6-pack beer a day for the past 20 years. His INR is elevated at 2.4, and platelet count is 91. He agreed to diagnostic paracentesis. What do you do about his INR and platelet count?
We are going to say we do nothing.
That is correct, you do nothing. So INR and platelet counts are appropriate surrogates for bleeding risk in many populations, but they don't include those with severe liver disease who already have elevated INRs or low platelets. The studies have shown that cirrhotic patients undergo large volume paracenteses. 22% will receive FFP and 17.3% will receive platelets, but the bleeding risk in itself is low, 0 to 0.99%, even with the high INRs and even with the low platelets. So what are the recommendations? Do not use them as indicators for a bleeding risk. Avoid routinely measuring INR or platelet counts. You don't need to routinely transfuse FFP or platelets as prophylaxis, although there's really no data with severe coagulopathy where peri-procedural transfusions help. There is also lack of data which shows that it does not help, and there are other complications. There's the risk of fluid overload, infection, anaphylaxis, and the American Association for the Study of Liver Diseases, again, recommends against correcting INR and platelets prior to paracenteses. All right, next case. An 88-year-old female with a history of dementia presents to the ED with dyspnea for the past 2 days. She is febrile at 101.5, vitals are otherwise stable. She's requiring 4 liters of oxygen supplementation. On exam, she has bibasilar rales, non-tender abdomen, leukocytosis, and chest x-ray reveals right greater than left bibasilar opacities. What antibiotics do you want to start her on?
Let me phone a friend. We're going A. We think A.
Correct and incorrect. So in this hospital, we are using A. Unison and azithromycin. However, we did have a recent antibiotic, like our stewardship, and they're recommending that azithromycin may not necessarily be the best recommendation, and there is a recommendation for doxycycline with Unison instead. So what are we treating in aspiration pneumonia? So historically, we've been adding anaerobic coverage due to concern of high prevalence of these organisms in lung abscesses or empyema. But routine coverage really is unnecessary if there's an uncomplicated aspiration pneumonia. Most of these cases are dominated by strep pneumo, Haemophilus influenza, or Enterobacter. In a systemic review involving 8 studies with elderly patients in uncomplicated CAP, 2 studies revealed evidence of anaerobes in the respiratory cultures, but they're really only noted in the severe aspiration pneumonia, and that was in 16%. Otherwise, most of the organisms were gram-positive, gram-negative, or both. So when do you treat anaerobes? ATS and IDSA guidelines recommend that anaerobic coverage should not be routinely added for suspected aspiration pneumonia unless there's a lung abscess, an empyema, necrotizing pneumonia, poor dentition, or gingival disease, or if there's a concern of aspiration of significant gastric contents from patients with bowel obstruction or gastroparesis. And then what about the workup for community-acquired pneumonia? Starting here, we would always check pneumonia urine antigen tests, Legionella, but really they're recommending against it. There's a very low positive or pretest probability at 12%. The positive results do not alter antibiotic management, and the results do not exclude the presence of other antigens. This can also lead to premature de-escalation that can lead to a negative consequence in such a relapse. And they also noticed that the POAT sensitivity has further decreased with the use of pneumonia vaccination. All right, so patient's oxygen saturation decreased to 93%. Do you want to give her oxygen? No, that's correct. So do we think it's necessary? No. So it's presumed, or there's this theoretical benefit of additional oxygen delivery, and that belief is that giving oxygen will help alleviate that dyspnea, but it can actually be harmful. So in certain patients, such as our hypercarbic COPD patients, SpO2 should be 88 to 92, and if you go above that, you have a 2 times increased mortality. It can worsen pulmonary shunting by reversing adaptive pulmonary hypoxic vasoconstriction. It can even cause lung injury, endothelial dysfunction, inflammatory activation, and systemic or coronary vasoconstriction. So that brings up the question, when should you give oxygen? So treat hypoxemia while avoiding hyperoxemia. So in patients with an MI, initiate oxygen if SpO2 is less than 90. For patients at risk for hypercapnia, maintain oxygen levels at 88 to 92%. And then for most other acutely ill patients, initiate oxygen supplementation if SATs decrease below 90 to 92, and a target SpO2 for most patients is going to be 94 to 96%. However, oxygen may be indicated despite normoxemia in certain cases. This includes CO2 poisoning, decompression injury, gas embolism, cluster headaches, sickle cell crisis, and a pneumothorax. All right, so next case. 50-year-old male with a past medical history of hyperlipidemia, hypertension, presented with localized erythema, pain, warmth, and swelling of the lower extremity for the past 4 days. He has no history of VTE or indwelling hardware. He denied any shortness of breath or chest pain. Vitals are notable for temperature 100.7, blood pressure is 157/72, heart rate is 92, respiratory rate is 18, and he's adding 98% on room air. He was admitted for left leg cellulitis. What is your next step?
What do we think? We're phoning a friend. Hold on. We're all agreeing. We're going to go with B, as in boy.
So actually, that's incorrect. The answer is just E, IV antibiotics.
So the answer is E.
E.
Gotcha. E.
E. So one of the first things we do with cellulitis, we order a venous duplex, right? We want to roll out that DVT. Now, cellulitis can present with similar symptoms: unilateral erythema, pain, warmth, swelling, mild leukocytosis, and it showed that about 73% of patients will have an ultrasound if they have a cellulitis diagnosis. When the Wells criteria with D-dimer testing often overestimates the DVT risk in these patients. So there is a low incidence of DVT. In a meta-analysis with 9 studies, they found a total DVT in 3.1% of patients and proximal DVT in 2.1%. And another retrospective study with 1,500 cases of cellulitis over 3 years. Of that, 240 had an ultrasound and 3 were found to have a DVT. So what are recommendations for ordering images in cellulitis? Really, it's not necessary to routinely order it if it's uncomplicated. Ultrasound should be reserved for patients with a history of a VTE, immobility, thrombophilia, congestive heart failure, stroke with hemiparesis, trauma, recent surgery, or patients who just do not respond to antibiotics. Now, what about blood cultures? Positive blood cultures present in about less than 10% of cases. In a retrospective study of 183 patients with uncomplicated cellulitis, 60 had blood cultures, 1 patient had a positive result. In another retrospective study of 757 patients, 553 were performed, 11 cases had positive cultures, 2 of which had risk factors for an indwelling catheter or hardware. In another retrospective study of 476 patients, 250 had blood cultures, 12 of that had bacteremia, and these were either with strep or staph. So what are the recommendations for uncomplicated cellulitis? The IDSA recommends against routine blood cultures for uncomplicated cellulitis unless there is hardware, there is suspicion of sepsis or other concurrent infection. The patients are immunocompromised, there are immersion injuries, or animal bites. So next case. The patient's blood pressure remained elevated with a systolic of 150 to 160, diastolic 80 to 90. He remained on his home regimen of lisinopril 20 milligrams and amlodipine 5 milligram. His blood pressure was usually well controlled at home. What do you want to do about his blood pressure regimen?
We're all going E,
Is
elephant.
correct. Keep him on the same regimen and have him follow up with his PCP. So what happens with intensifying blood pressure regimens prior to discharge? So there's usually an increase in medications in response to short-term elevations in blood pressure for non-cardiac conditions. This will be stress, anxiety, a pain response, agitation, or a medication adverse effect. They've noticed that there's an increased risk of readmission and serious adverse events within 30 days. These patients can have falls, syncope, hypotension, electrolyte abnormalities, or even an AKI. All right, next case. 84-year-old nursing home patient is evaluated in the ED for lethargy and fever. Medical history and medications are not immediately available. On exam, she is febrile, 102.7. Blood pressure is 88/50. Heart rate is 116. Respiratory rate is 26. She's satting 95% on 3 liters. She's confused but responds to commands. The exam shows tachycardia, normal heart sounds. There are rhonchi over the left lower lobe. She was appropriately fluid resuscitated. What is the most appropriate next step? A is correct.
A.
So assuming this isn't just pneumonia, usually with our septic patients, we go broad, bank Zosyn, bank Ceph. We've always seen, or some providers tend to shy away from Zosyn due to risk of AKI. And this led to the ACORN trial, antibiotic choice of renal outcomes trial, compared cefepime and Zosyn in adults within 12 hours at a 1-to-1 ratio. And this had 2,500 patients. The incidence rate for major adverse kidney events at day 14 was about 12.2% in the cefepime group and 8.8% in the Zosyn group. Incidence of death in cefepime group was about 7%, and in the Zosyn group it was 7.5%. 6% died regardless of antibiotics. So among the hospitalized patients, treatment with Zosyn did not really increase the incidence of AKI or death. There's really no significant difference between the 2 groups. So blood pressure remains 84/46 despite recommended fluid resuscitation. Pressors are started. Does this patient need a central line? No?
They're saying no.
Not at that point. So pressors are usually believed to cause skin ischemia or necrosis, so oftentimes in this hospital we'll automatically put in a central line. But studies have looked at the safety and outcomes of pressor use peripherally versus centrally. In the two studies that'll be mentioned, 139 out of 1,100 required pressors. 108 had peripheral access and 31 had central access. The duration in peripheral access was 2.5 versus 4.2 days in the central access. Phlebitis and extravasation occurred at similar rates between the two groups at 5.7 versus 3.3 and 0.9 versus 3.3. The bleeding rate in the central group was 3%, and it was 0 in the peripheral group. In another study, 734 received pressors peripherally. Complications happen in about 2% of patients, so 19 of that 700, and then 13 eventually required central access. All right, so next case, 84-year-old male is evaluated before hospital discharge following a heart failure exacerbation. Medications include lisinopril, furosemide, carvedilol, spironolactone. During the hospitalization, the patient was diuresed with IV Lasix and is now euvolemic. Echocardiogram showed an EF of 25%. What recommendations would you give this patient in regards to salt and fluid intake? So we have a common bias. So every untreated heart failure patient results from retention of salt and water. And this led to the foundation that heart failure patients should have dietary restrictions. They have less than 2 grams of salt per day or maintain 1.5 to 2 liters of fluid restriction. And based off of the European Society of Cardiology heart failure guidelines in 2021, they did actually recommend avoiding large volumes of fluid intake for all patients with heart failure. There was a recent study that came out. 75 patients were either given a fluid restriction or sodium intake, so less than 800 cc's per day or 800 milligrams per day, versus a liberal intake of greater than 2.5 liters per day and 3 to 5 grams of salt per day. They found that there's no significant difference in IV diuretic rates, weight changes, or clinical stability during the 3-day follow-up period. In another cross-sectional study involving 302 patients with heart failure, there was also no significant difference in the time of clinical stabilization in patients with acute decompensation between those that had fluid restriction and those that had liberal fluid intake. So what are the new recommendations? So the European Society of Cardiology heart failure guidelines now advise the limitation of salt to be no more than 5 grams per day, and they're contemplating fluid restriction of 1.5 to 2 liters in only select patients. So for both chronic and acute heart failure, normal fluid intake is suggested, and that's mainly guided by the sense of thirst. In patients with acute heart failure, there should be a decision-making or discussion in regards to restriction of fluid in order to just manage sodium levels and dilutional hyponatremia, but otherwise the main objective is to achieve an overall net negative fluid balance. So primarily focusing on an adequate diuretic response. So what are things that we should do for good reason? So ultimately do what's best for the individual patient. Practice effective health care that uses resources responsibly. And really what they recommend is going back to basic clinical skills. Recognize that technology can improve care, but we shouldn't depend on technology solely as a diagnostic tool. And what that article had gone into a little bit more is that a lot of billing goes based on our tests that we order and the results, but not necessarily what the patient's experiencing, what's in the history, or what's on the exam. So focus on taking a carefully crafted history, perform a skillful physical exam, communicate effectively and compassionately with patients at every encounter. So how can we lead the change towards high-value care? So order interventions or services that add value to patients' care. Carefully weigh costs, including charges and downstream costs, harms and benefit. Reduce diagnostic uncertainty through appropriate use of evidence-based guidelines and decision-supported tools, and advocate for healthcare reform to support system-level high-value care. And I want to thank Dr. Gross, Dr. Newcomb, and Dr. Me. That was
Thank
good.
you so much.
Thanks.
Excellent talk.